Okay. Welcome, everybody. My name is Mike McKee. I'm an associate professor here at Department of Family Medicine and also have a secondary appointment at Physical Medicine Rehabilitation. And I'm really delighted to welcome everybody to this. This is really going to be a new pilot program. It's a disability health objective structured clinical exam, and we have several scheduled training sessions. And this is intended to help prepare medical students for the upcoming OSCE event. This will be hosted here at University of Michigan CLEX library facilities, and that more information will be coming, but it will be scheduled sometime in early April. The pilot program is supported by the Research and Training Center, and our training center is titled Advancing Health Equity Among Adults with Disabilities from Diverse Communities. We have a name of a head-DC. This center is also funded through the National Institute on Disability, Independent Living, and Rehabilitation Research, also called NIDILRR. And we're aiming to examine and address systemic issues in healthcare that negatively affect people with disabilities, especially through intersecting identities. And those are individuals we have already recognized that are more likely to experience compounding inequities, discrimination, and health disparities. So I'm delighted to have three panelists. Our third panelist will be joining later on today. First one is Dr. Brianna Marsoff. Second is Carrie Bradley and her son Daryl, and Dr. Steve Erickson. And they're going to be discussing how to sharpen your clinical skills working with patients with intellectual and developmental disabilities and to practice inclusive care. The panelists will share some tips on best communication practices and key exam approaches. We're going to be sharing tip sheets and key points in the chat and also with email, and we'll show a folder where you can access this later. This is the first of several training sessions, and this will cover intellectual and developmental disabilities, sensory and physical disabilities. And this is really to give you skill training to be able to interact with our different standardized patients coming up. And these are individuals with lived experiences and different types of disabilities. So we are hoping that you can put your learning into action with a hands-on OSCE training event in early April. So first, I want to introduce our first speaker is going to be Dr. Brianna Marsoff. She's a passionate champion and is very committed to improving healthcare for individuals with intellectual developmental disabilities. And by leading initiatives that prioritize accessibility and inclusivity, she's really determined to bridge the gaps in healthcare services and empower individuals with IDD to lead fulfilling lives. She is also our first Disability Health Fellow at the University of Michigan, and she is excited about this role and is also setting up a new novel model clinic called My Care, MI-Care, for intellectual developmental disabilities. So Dr. Marsoff recently graduated from the University of Michigan Family Medicine Residency Program, and she also has completed a 2-year healthcare administrator scholars program to further enhance her understanding of healthcare management and administration. She completed her medical education at Michigan State University College of Osteopathic Medicine in 2020. Second is Carrie Bradley. She is a passionate advocate for disability rights in the Metro Detroit community, and she identifies as legally blind and a caregiver to her son, Daryl, who is joined here today with Down syndrome. Carrie graduated from Detroit Public School and Wayne County Community College. She teaches Braille and digital literacy skills throughout Metro Detroit and serves as a board member on Warriors on Wheels. She is also a member of the National Federation of the Blind and Helping Hands. As both a patient and caregiver for her son, Carrie is eager to promote healthcare inclusivity. And then last is Dr. Steve Erickson, who will be joining later, is an associate professor at the Department of Clinical Pharmacy at the University of Michigan College of Pharmacy, and he received his bachelor's of pharmacy from Ferris State College and a PharmD from Wayne State University. He also has a son with intellectual and developmental disability, and his interest is around comprehensive medication reviews to improve the medication safety and quality for those with IDD. So I'm going to turn it over to Dr. Brianna Marsoff to give us some tips and communication strategies. And Brianna?
Thank you, Dr. McKee, and good morning, everybody. Sorry about the little bit of delay getting started here. Just to give you a little bit of a plan, I'm going to speak for the next like 10 to 12 minutes or so, and then I'll pass it over to Carrie and Daryl to share their perspective as a caregiver and a patient. And so I believe in the chat you can see a tip sheet that we've all worked together to put together. And I hope that this is helpful for you when you're preparing for your patient simulation encounter. I think that this is a really neat opportunity that I didn't have in medical school. Many of you might know that there are no requirements really to learn about disability health in medical school. So it's really a great thing that U of M is piloting this initiative. And I think it's just important to recognize that, 1 in 4 people have some type of disability. So we should be, prepared to care for these patients in the clinical setting. But it's okay if we make a mistake. And if we say something when we're trying to communicate that maybe we didn't mean or that came across wrong, I think oftentimes families just respect if we're doing our best and if we say we're sorry and we learn from it for next time. So I think, I know that all of the patient encounters can be kind of a stressful experience, at least when I was in med school, but I hope that this can be more of just a learning experience. And in general, I think we're all just trying to get, I've had tongue ties and said things I didn't mean when I have the very best of intentions. And so just, I'm going to give lots of tips and tricks. You don't have to memorize all of them. Just do your best and try to keep these things in mind. And I might say some things that Carrie or Daryl disagree with. And so I would love to hear from them when we jump into their section. So I'm not going to share my screen because I think you guys have the tip sheet and you can kind of follow along. But basically, it kind of goes through when we first meet the patient, some basic communication tips, some things to think about during our physical exam, and some things to think about when we're developing an assessment and a plan. So I think the first thing is we introduce ourselves to the patient. We walk into the room and we say, hi, I'm, student doctor, whatever, and we introduce ourselves to the patient. And we shake their hand and we say hello. And then we say, who's with you today is often kind of how I try to address the support person. And it's important to recognize that there's, kind of 2 categories of support people that might be accompanying someone. Okay, so we introduce ourselves to the patient, we say, who's with you today? And we're trying to get an understanding of who their support person is. There's kind of 2 categories of support people that I kind of think about. There's the support person who is like Carrie, who's a family member who knows the patient better than anybody in the whole world, who's a wonderful advocate, who we should listen to when they have concerns, and we should take them seriously, even if they seem, oh, well, usually patients don't present like that, but we should take their concerns really seriously. Then there's the caregiver that maybe doesn't know the patient so well and is maybe a paid caregiver who works at the group home where the patient resides and sees the patient once a week and happen to have some availability to bring them to their appointment. And so sometimes their support person really doesn't add a lot to the history and to the conversation. And so it's important to kind of recognize that there's maybe two different kinds of caregivers. Oftentimes it's the first one. It's somebody who really knows the patient very, very well. But we shouldn't assume that the patient wants their caregiver there with them. We should give the option and we should say, would you like your mom to stay here with us during the visit? Okay, usually they will. So I can kind of clarify that point if I haven't made it clear. But I would say in general, their caregiver is their number 1 advocate, their number 1 support person. But unfortunately, sometimes there's somebody that maybe really doesn't know the patient super well, and we have to call their guardian and kind of get some collateral information after the visit. Carrie and Daryl, that's not the case. They're the duo that we love to see in the patient encounter. So once we do that, then we I'll talk about some kind of verbal and nonverbal communication strategies. We don't need to talk loudly necessarily, but we need to talk slowly and give some time for processing. using short, simple, plain language can be helpful. And we should repeat and rephrase things as needed. We should avoid using abstract concepts that maybe patients might take literally, when we're asking, does your throat hurt? Rather than, is your throat on fire? Carrie shared some really great examples, and I think in general, we learned that we should ask open-ended questions. But in some situations, and often when we're trying to get a history from a patient with an intellectual disability, using more closed-ended questions is more helpful. So yes or no questions. Please show me where something hurts. Does it hurt a little or a lot? Rather than having them rate it on a scale of 1 to 10. Asking very specific questions. What did you eat for breakfast? Not when is the last time you ate? So simple things like that. And you'll get a feel throughout the interview if maybe what you're asking is it needs to be rephrased. And so that's okay. We can ask things a couple of times. We should assume that patients understand what we're saying to a higher degree than they're able to express their feelings. And so oftentimes when patients are minimally verbal, we assume they have a greater level of intellectual disability than they really do. And really, they just need the right communication tool. And they need a communication board where they can point to things, or they need their iPad. And so assuming that they understand what you're saying, I think is important. But we can check for understanding, repeat and rephrase as needed. I think using meaningful gestures can be really helpful. When you ask if their stomach hurts, you can point to your stomach or point to their stomach. And I think we talked about giving time for processing, trying not to interrupt the patient when they're talking. Even if they're struggling to get something out, giving it some time. Sometimes we're not going to know what they're saying, and that's okay. We can say, I'm really sorry. I know you're trying to explain something to me, but I can't understand. Is it okay if I try to guess? Or you can look to the caregiver to help try to clarify what they're trying to express. So those are just some basic communication tips, and we'll move on to the next section, which is our physical exam. And so, oh, and I did want to mention, if they have a communication board with them, we should use it. I've had a number of times on the inpatient side where I walk into a room and a patient's communication board is on the other side of the room where they can't reach it, and I bring it over to them and they point to scared and alone. And I think, oh my gosh, this is how long have they been feeling this way? And they can communicate, we just haven't given them the tools. So using the tools that patients have, I think is really important. When we're doing our physical exam, we should explain what we're doing every step of the way. And I think when you're doing your simulated encounters, if I remember, you kind of have to do that anyway. I'm doing this, now I'm doing that. And you're talking things through anyway. And in this case, that's very applicable. So you're going to explain what you're going to do. You can show them, I often say, is it okay if I listen to your heart now? And then sometimes they want to hold the stethoscope or play with it. Okay, let them use the equipment. And if they say no, yeah, I don't want you to listen to my heart, then no means no. And I think that's really important to recognize that many times in the healthcare setting, they've said no, they didn't want their blood drawn or they didn't want a shot at that time, and they got held down, and it would happen to happen anyway. And that's not the kind of care that we want to practice. If they say, no, I don't want you to listen to my heart, okay, so now we move on to something else. And then when I come back later and I say, can I listen to your heart now? Oftentimes they say, yeah, you can, because you've built this trust that you're going to listen to them when they express something. And so it's okay. Maybe we can't get vitals when they first come in. And I always tell my MA that it's okay. You don't have to force it or push it. We'll develop some rapport and talk with the patient, and then we'll move into trying to get the vitals and doing the physical exam. And sometimes we can't do either. And the visit is more for rapport building. I've had a visit where the patient couldn't get out of the car and they had a long car ride. They were really nervous about the visit. It was our first time meeting. And so I did the visit in the car, and we didn't do any vitals and we didn't get a physical exam, but we got to know each other. And the next time they came into the office, they stood on the scale, we got all the vitals, they even put on a gown, and we got a great physical exam. So letting the patient lead, I think, is really important. When we're doing our physical exam, we should go slow and check in. Is this okay? What I'm doing, is this okay? We should prioritize save the harder parts of the exam for the end. So sometimes, ears maybe is difficult. Definitely gynecologic things should happen at the end, or testicular, GU region. Those exams, if they need to be done, I would wait, do those at the end of your physical exam. And our physical exam should be very thorough. So especially when patients are presenting with a behavior change or some unknown pain cue. Maybe they haven't told their caregiver everything. Maybe they can't. Maybe they don't know. Maybe there's something that we didn't get in the history that we'll find on physical exam. And so not for every patient, it depends what the chief complaint is, but oftentimes if there's an unknown pain or behavior change, I will look at their skin everywhere, make sure there's no pressure sores or rashes that are bothering them. And looking at their feet, I think, is a really good indicator, like general indicator of their quality of care. And we can have an ingrown toenail, we can have calluses, we can have things that are causing pain there. So doing a really thorough exam. And when you're doing the exam, observing their facial expressions to try to gauge their level of pain. I think you learn this in pediatrics, when you're feeling the belly, looking at their face. They might not tell you it hurts, but they might wince, or they might have some guarding present. And understanding that sometimes patients, they present differently. I had a patient with Down syndrome who was in the hospital because she'd had a hysterectomy and they had nicked a ureter. And so she had ascites in her belly, but it was urine. And she looked very, very comfortable. She looked happy. She was coloring, she was drawing. And her mom kept saying, no, there's something wrong. There's something wrong. I know because her toes are curled, and her toes are only curled when she's in a lot of pain. And so, that's an example of listening to the caregiver, and also that, patients' pain cues might be different, but it's important to try to use what we can, and facial grimacing might be one of those things when we're doing our exam. So, okay, that's I think our physical exam. We're explaining what we're doing, we're going slow, we're letting the patient guide us, we're getting through what we can, and if we can't get through things, then we defer, and we document that in our note. And then let's move to our assessment and plan. I think it's really important to, this is pretty obvious, but engage the patient when we're discussing our treatment options. And I'll share an example of what that means. I had another patient with Down syndrome who had terrible fungus of his feet. And it was because when he got out of the shower, he put his feet right into his socks and then put his socks into his work boots, and he did that all day. And the moisture collected and he got this fungal infection. So he was seen in the ER and he was seen by dermatology, and both groups wrote in their note, do not wear socks. That's our assessment and plan. That's our plan. And when I saw the patient, things weren't getting better. And I tried to understand, what's going on? We don't want to just assume, well, they're not listening. They're not listening to my recommendations. Well, come to find out, the patient really loves socks, and it's part of some of his kind of OCD behavior that socks are a part of the routine. And so we kind of made a plan together, and we said, okay, your caregiver agrees to help you dry your feet really well when you get out of the shower. You can wear some breathable special socks, but don't wear your work boots, wear Crocs, so we get some better airflow. And so we can't just, so when we make a recommendation, we should think about, is this feasible for the patient, and what are barriers that they might have. Another example with the same patient, and then I'm almost done and we'll pass it off to Carrie, is there was a recommendation he should soak his feet in vinegar water twice a day. This wasn't happening. And then we learn why. Well, because the instructions aren't clear. The caregiver didn't know how to mix the vinegar in the water, and the patient really didn't like doing it. And so we, in the office together, we mixed the vinegar in the water in a little bucket. He got a little pedicure in the office, and he went home with the basin. And that was his, this is your basin, and you're going to use this to soak your feet in every day. And that was a plan that everybody was on board with, and really, ended up working after a couple of weeks. And so writing things down, providing clear written instructions that are direct and simple. As with any patient, dosing the medications, as nobody wants a 4-time-a-day antibiotic. If we can do twice a day, that's better. But I think engaging the patient and the caregiver and recognizing that there's nuance and room for compromise, and we have to maybe think outside the box a little bit. And then we summarize and we check their understanding, and is this going to work with you? Lastly, I just want to say that, abuse is prevalent in this population, unfortunately. And if we have any inkling about abuse, we have to ask, to speak with the patient alone. And we say simple things. Are you scared? Is anyone mean to you? Does anyone hurt you? Simple kinds of screening questions there. But, and, so that's just one thing to keep in the back of your mind and on your radar, unfortunately, we have to think about. And last thing I wrote was, this is not for your OSCE, but in general, in the clinic, if we can modify other stressors. I usually don't wear my white coat. You probably will have to for your simulation encounter, but sometimes I think that adds a little bit of stress for patients. And so if we could offer blankets or noise canceling headphones, things like that can be helpful for patients. And like I said, it's okay if we make a mistake. We just want to apologize and recognize it and learn from it and do our very best. And that's that. I talked for too long. That was longer than I wanted. I'm sorry. Carrie and Daryl, I'll pass it off to you, and correct me if I said anything that you disagree with. What are your thoughts?
Okay, good morning, everyone. When I looked at my phone, it said that it was like 16 people here, and I was trying to read the tip sheet and I couldn't. One of the most important things that you future doctors need to understand is technology is something we are fighting to get right. Um, the what do you call it? The iPhone, which I'm using, has Siri and it has voiceover. Most computers has a program called JAWS, Job Access with Speech. Daryl did have a little practice with this one machine, but he could not type in the words so the machine could say the words for him. Daryl, say hello. Daryl is 30 years old. He was diagnosed with Down syndrome when he was 2 years old. I took him around from doctor to doctor because I knew something was wrong with him, but I didn't know what. And one day he was at the pediatrician for regular physical, and the doctor walked in, and because my regular doctor was on vacation, and he walked in and said, "You do know that your son has Down syndrome, don't you?" And I said, "Well, thank you. It's a name." Okay, so that's when his education started. He went to the Detroit public schools, and he was in since he was 3 years old. The first school they sent him to was Detroit Day School for the Deaf. Before then, a teacher came out to the house once a week and played games to enhance his physical and mental capacity. So right now, he graduated from Jerry White, and then he went to Drew Transitional Center. He graduated from there, and now he's in a program called Services to Enhance Potential, STEP. So I'm sure you can look that up and see what that's about. One thing that people with disabilities need is a program. They need some stability, something to do, because like she said, they are what's the word I'm looking for? Uh every day they want to do the same thing. Same thing. They have a program and they follow it. And when doctor's appointments come along, that's out of their program. So it automatically gets their mind in another vein. So by saying that, I've had some bad experiences with doctors, and I've had some good experience with doctors. Daryl has had pretty good experience with doctors. And when a person like me comes in with Daryl, number one, I don't want you thinking that I'm high on drugs, because my eyes, they roll around and I can't keep them focused or steady. I don't know if that was in a tip sheet or not, but if you take a good look at my eyes, you can see they can't focus. I see absolutely nothing. It looks like a TV screen that doesn't have a picture. If you remember those TVs you can turn on, that's what I see, with all of them dots that's ready to make a picture but haven't made one yet. Daryl's intelligent level, I would say, would be somewhere around 10. And that's only because he's been here 30 years. He cannot read words, but he can understand what a word is. For example, on the mail, he knows which mail is for me, for my daughter, for himself. He doesn't have any understanding of money at all, because 10 $1 bills to him is the same as a $20 bill to you. We need to, when you're examining the patients that have Down syndrome, we need to understand that they're people too. They know where they hurt. They may not communicate it to you, but they do know where they hurt. They can tell you that their head is hurting, and if it's not hurting right now, it might have been hurting yesterday and 2 days before yesterday. So a question would be, does your head hurt right now? And they'll say no. Say, when is the last time your head hurt? Was it yesterday? And put up your fingers 2 days ago, because they understand hand movements. A lot of them learn sign language also, which I think is a good thing. Daryl is, right now, he has a girlfriend. What's her name, Daryl? Now, I don't know how many of you understood the name that he said, but it's Brianna. Daryl, I want you to talk for a few minutes, and I want each of you to think about what he's saying, and how many sentences you actually understand. Go ahead, Daryl. Tell them something about you. Now, he said, I take the garbage out, I get my clothes ready, I go to bed, and then I go to work. These are some of the language difficulties you're going to have to learn how to work your way around. I understand him, but I've been with him for 30 years. Okay, so that's what I'm feeling. Far as people who are abused, I sort of disagree with her, because I think 75% of the people with disabilities are abused, and most of them are afraid, and they don't know who to tell. So it's very important for you guys to make sure that you look at these patients for signs of abuse. It's like looking at a child after being hit, by a parent or an uncle. You have to look for these cues. Being in the Detroit and having relationships with numerous people with disabilities of all kinds, I have seen these things happen, and that's why I'm such an advocate, and I want excellent care and quality of life, not only for myself and my son, but for the other people in Detroit with disabilities as well. Thank you. Say thank you, Daryl. Thank you. I hope somebody's still there.
We're all here. Thank you, Carrie. Thank you, Daryl. And I think that was a really good, I'm glad we could hear you speak, Daryl, and tell a little bit about yourself. And it shows such a great example of how Carrie understands him really, really well and is able to help us understand his needs. And I do agree completely that abuse is something that we have to consider. It's very prevalent in this population, and we must screen for it and keep it on our differential. Absolutely. And there's some questions on the handout about some simple ways to ask a patient about it, but they might not tell you. And that makes it difficult, but that's the case probably for a lot of patients who are experiencing abuse. And so we have to consider it and be diligent and take the right steps.
We
Steve?
must understand that a lot of these caregivers slash places that take people with disabilities in, they're in it for the money. They're in it for the money. So as healthcare providers, I feel it's your job to make sure they stay healthy and safe.
Thank you so much, Carrie and Daryl. I appreciate your input. And hopefully we'll have some time for questions, but I want to go ahead and switch over to Dr. Steve Erickson. Welcome and good morning. And so we'll pivot over. Steve, you should be able, if you have anything you want to briefly share, you should be able to do that. Otherwise, it's all yours.
Thank you very much, Dr. McKee. Dr. Marsloff, Dr. McKee, thanks for putting this together and having me and Carrie and Daryl here. And Carrie and Daryl, I so much appreciate you being here. Daryl, how you doing today?
Good.
Doing good. All right. I'm coming here today, or being here today, I'm wearing two hats. That is a father of a son, my son named Christopher. Christopher is a 33-year-old young man with Down syndrome. So Daryl, I have a son who goes to STEP, just like you, who has Down syndrome. And he's there right now doing something. I'm not sure whether it's in his art program, the gym, or he might actually be, just to let the rest of you know, STEP does a lot of things with the clients, anywhere from helping them attain a job with a good income, more likely though a job with some income but a lot of experience, all the way to, for example, my son working in a half a day a week putting parts together, small jobs where he earned 10 cents. So,
right.
but
Piecework.
Piecework, exactly. But again, I can't stress enough the importance of these sorts of programs, whether day programs, supported employment, to keep people engaged in the community, because this has a lot of ramifications beyond just engagement. Their mental health, their physical health, and their social well-being becomes so important. All right. I'm wearing two hats. That is a clinical pharmacist who's working with Dr. Marsloff and McKee on a number of projects here, where I do medication reviews within supported living environments, such as group homes or apartments where people are living with supportive staff, as well as their own family homes, or doing med reviews over Zoom. I have over about 35 years worth of experience as a clinical pharmacist, and it's been the last 10 years that I've really focused on people with disabilities, particularly intellectual and developmental disabilities, looking at the healthcare and the disparities in health outcomes that people with disabilities in general experience compared to the general population. I'm going to kind of bridge for a few minutes from my clinical perspective, my education perspective, as well as my parents' perspective. Some of the points that have already been made, and a couple other things I want to talk about. One is communication. Dr. Marsloff had some great comments there, as well as Carrie. One thing I can't stress enough is the patience. Patience working with your patient. Just to give you a quick with communication, our son Chris, it has sometimes it takes him a while to get things out, including minutes before he'll actually answer a question. Give you a quick example. We were shopping for a coat one day, my wife and I and Chris. And Chris was looking at different ones, and he got a little bit overwhelmed, and so we stopped the shopping, and we went over to Panera Bakery. And about 40 minutes later, Chris said, "Red one," and I go, "Red one what?" And he goes, "Red coat." It took that long for him to process because he was a bit overwhelmed at the moment with all the information overload. But 40 minutes later, he came to the point where he made a decision. And that is extremely important for you as a clinician when you're working with patients to understand. And Dr. Marzloff pointed this out. You may not get information right away. It might be you're really in that rapport building phase initially. And down the road, you will be able to communicate better. But keep in mind, don't finish their sentences, keep it simple, and be patient with the person. I also want to point out a few things about behaviors that was mentioned by our previous panelists here. Behaviors, again, are often signs of something else going on. Abuse, as was already mentioned, boredom, could be physical related, pain. I have numerous examples where what's called diagnostic overshadowing, where we as clinicians attribute something that we observe or we're told that others are observing as being related to the disability or the impairment, when in actual fact it's related to something else. Like an example of one of my son Chris's friends had a gangrenous gallbladder, but he was exhibiting challenging behavior for about a week that was being attributed to Down syndrome and autism, but in fact, it was a gallbladder that had become gangrenous before a third clinician actually took the time to work with him. So it becomes really important to do that. I also want to point out something else that I've noticed in my medication reviews, the documentation. As clinicians, your medical record becomes really important, not only for you, but for other clinicians coming along that are part of the team working with you. And documentation of the individual, certainly the impairment that's present, but also things that strike you as to help build rapport with that patient. And having that documented is good because other clinicians will be able to see that and understand, when they go to meet with the patient, they'll understand already some of the positive things that you've identified that work with the person that will help them build that rapport with the patient that you're working with. That becomes really important. All right. A lot of what I was going to say is already said by our other panelists. So I can't stress enough the importance of patience. Understanding nonverbal communication becomes really important. Documentation and behaviors. Those were the main things I had written down. I'm going to stop there and leave it. I think it'd be great to have some question time or fill in any other gaps here.
That sounds great. So we do have a little bit of time for questions and answers. And just to recap, we will share this really incredibly helpful tip sheet, some care points. We'll share it by email. We will have a location where you can access it later. For those who are going to join our upcoming Disability Health OSCE, I encourage you just to refresh prior to that event. You've already heard loud and clear that it is really critical to have good communication. That's just for everybody, but there are some nuances, some strategies that really can help improve the communication quality, effectiveness, especially as you engage individuals with intellectual and developmental disabilities. Keep in mind, everybody is different, and that's why it's important to be open-minded approach, learn from them. So that cultural humility is so valuable, and I encourage everyone to practice that all the time. So I'm going to open it up for questions if you want to put it in the chat, or if you want to quickly jump online. I am going to read any questions from the chat just to make sure that Carrie can follow along as well. Are there any questions? While we wait for questions, I do have a couple that will just kind of kickstart things. So you heard a couple things about their communication, trying to make sure that it's good. It's going to take some time. how do you manage the need for longer appointments? There was also, Dr. Marsoff mentioned that sometimes it's hard to get some exam or vital signs, especially that first visit, establishing a good report. How do you document that? Because we're kind of trained to make sure that that be part of our documentation for billing purposes. And the question for Carrie and Daryl, are you willing to come back for multiple appointments if we have to break it up? So I know that was a multiple prong question, but that's a question for everybody here. Who wants to go first? Brianna, do you want to maybe just talk a little bit about how you do it, how you document and manage some of the appointment issues, the timeline?
Sure. I mean, I think the time is difficult. That's to me, that's one of the biggest challenges. And that's something I'm working on, with Michigan Medicine and trying to advocate for a greater equity in giving patients with intellectual disabilities longer visits, like we do for many of our patients who are geriatric patients or palliative care patients who have a longer problem list and take a little longer to communicate and have a caregiver present. So if you can schedule extended visits, that's wonderful. I think documentation wise, we just have to describe exactly what happened. But, attempted to obtain vitals, patient declined, tried on 2 attempts. And, you can comment on chart review. Blood pressure has been relatively stable, or blood pressure has been pretty high on chart review. And maybe we should try to monitor at home. Maybe we could get the patient an ambulatory cuff and see if they do a little bit better at home. So thinking outside of the box on those kinds of things. But I think just documenting exactly like it happened, and you don't have to make excuses. You don't have to say they were uncooperative or non-compliant. You just say patient declined, patient refused, attempted again, that kind of thing. Anybody else Carrie, did you want to have anything to add about coming back, and Daryl coming back for more visits, more frequent visits? Or sometimes I offer telehealth visits, phone visits, check-ins if transportation is difficult.
Yeah,
Sure.
Carrie switched over to iPhone, so she's still with us. Carrie, feel free to let us know if you have any thoughts. And Daryl, same thing for you too. Well, we can maybe perhaps give a minute for either one of them. Steve, any thoughts about perhaps structuring it where you talked about needing time for just processing? Any thoughts about multiple appointments?
Multiple appointments are actually quite helpful. You may not get a lot done that you might anticipate getting done on that first visit, but having follow-ups is really important. I'm working with a number of national organizations around health-related issues and people with IDD, and one is Special Olympics International, and they're actually working to put together a webinar on how do specialty clinics actually bill for complex cases, which often our folks with IDD present. They're complex cases with not only their health care, but also the support, the paperwork that you'll need to fill out and that sort of thing. So there are stories of successful reimbursement for complex cases, but it's hard. It's hard, especially getting your bosses to give you the time often. Absolutely.
I was just going to say that Navia, I think that kind of answers one of your questions about what kind of support systematically or at a clinic level do healthcare providers need. One of them, I think, is support in the time for the visit and learning about billing strategies, and we can talk about more as well. But go ahead, Mike. Sorry, I interrupted you.
I was just going to read the question, so thank you. Steve, Carrie, Daryl, any thoughts about that question?
Oh, again, around the structure of the clinic and so the structure around it, that's the question?
But yeah, systematically or at a clinic level.
Yes. So from the clinic level, having intake people, your supports employees within the clinic, also understanding how to work with people with intellectual disability, or sensory. It becomes really important to have a waiting area that's friendly for patients. The amount of time they have to wait, make it minimally, because anxiety builds as people wait in the waiting room, and having staff that are understand the needs of our special patients goes a long ways. That welcoming, friendly environment will just reduce one barrier to getting the person to come back regularly.
I totally agree. I know for our clinic at Dexter Health Center, we have a point person, which we put a lot more investment training to make sure that they're comfortable in caring for different patients with different types of disabilities. And so really advocating and telling your clinic manager, your whoever your director or supervisor is, just to say, this is what it's going to take to be able to give good quality care. I think just being an advocate, speaking up, really goes a long way rather than waiting for a problem to arise. And then likewise, I also really strongly encourage to get as much information before the appointment. What can make the appointment helpful? And the disability accommodation tab that we have in my chart at University of Michigan, and some places have their own format. I encourage you to take advantage of that, have that populated so you can put information that will help the team and providers know what to do. So that's going to be really critical. So, okay.
I was just going to reiterate, the disability accommodations tab is wonderful. You'll maybe see that in my chart under the patient's profile and their name, what accommodations they've requested. And if they haven't filled it out, we should encourage them to. I'm working with a lot of the clinics on a sensory toolkit. So having those weighted blankets or headphones available, recommending that we room patients. Maybe they don't, maybe not, maybe waiting room isn't the best place where it's overstimulating. Maybe we can get them into a room quicker. Those kinds of things. And then just systematically, I think what we're doing here today in terms of educating our, medical students, and then you can go on to pass this information to other people in the clinic who maybe never had a chance to receive this education.
Okay. Well, we have a couple other questions here. Kate Panzer said, I'm looking forward to the OSCE in April. I'm curious about the training process for standardized patients. So we have 7 individuals who have joined this pilot program. They all have different types of disabilities. And so we're going through the same type of training, making sure that they have a script to follow. So this whole process is going to mirror what it already happens at the medical school level. We are not part of the medical school standardized patient program. That is an ultimate and hopeful goal, is to basically merge and assimilate into that program so that medical students have an opportunity to work with standardized patients with lived experiences. And so that is coming. More information will be shared. We will also have additional training sessions. Our next one is going to cover sensory disabilities. We're going to focus on deaf and hard of hearing for our next one. So be in the lookout for upcoming sessions. If you are not able to join, that's okay. We will have them recorded too. But please spread the word and join when you can. There is another question here. Brianna says, what kind of training did you receive during the family medicine residency regarding how to care for patients with IDD? Did you feel prepared to care for these patients upon finishing the program?
Well, one of the big reasons why I was so excited to come here for residency was because of the work that I know that Disability is doing, and the emphasis on disability health here at Michigan. I think you will see people with intellectual disabilities if you look and if you kind of open your eyes to it. They're every time I was on the inpatient service, there was a patient, I would say, that fell into this category. I was able to see many of these patients in my clinic, and I continued to. I think that's one of the reasons why I'm doing this Disability Health Fellowship, which is a new fellowship that we've created, is to offer further training, because I don't think we ever feel totally ready and prepared. And so this gives me the opportunity to work with other specialists, psychiatry, pharmacy, physical medicine and rehab, neurology, genetics, and learn more so that I'm better prepared. We have pediatricians that can specialize in this population, but really nothing on the adult side. And so and we're working on developing more curriculum for the family medicine residents here, and with at least lectures quarterly, and incorporating some curriculum there.
Thank you. The other, Carrie, were there anything you want to share?
Okay, can you hear me now?
Yeah, we can. Awesome.
I've been trying for the last 10 minutes to unmute this audio. I really want y'all to understand that technology is not a friend to people that are blind. Daryl can manage a lot of the things when it comes to computers and connections, but not all. So, what was I was going to say something. One of the things we need to understand is, maybe if you do some of the exams, you can get some of these done at the caregiver. I mean, at their house of residence. For instance, to go actually to the safe. I mean, the places where they live, and give them an examination if there's more than one person with a cognitive impairment in the house. That's a patient. That could be something else. As far as when you're writing prescriptions, one of the things that would be really good is to make it as simple as possible. If you can give one capsule, because like I said, they are on routines. They do things in an orderly fashion the same way every day. They want to eat at 8 o'clock. They want to have lunch at 12:15. They want to go home at 3:30. We have to take those factors in account when we are giving them examinations, writing them out prescriptions. And I think we need to stress what's not good for them. Because I'm trying to put Daryl on a diet, and I would say, Daryl, you don't need to drink pop. You don't need to drink pop. But when we went to the doctor, and I told the doctor, I said, well, I'm trying to make him cut down, but he drinks pop all day long. He looked at Daryl and he said, Daryl, listen to me. Pop isn't good for you. It's going to make your belly bigger. And he tapped his stomach. And Daryl has cut down drinking pop. And he tells me, Mama, pop not good for you. So, it has to be a joint venture between the caregiver, the physician, and the nurse. Because your nurse is going to play a part in there too. Because if the nurse cannot make these adults, children with disabilities feel comfortable, your battle is already lost. It's already lost.
Thank you so much, Carrie. So I know we're a little bit past the hour. So first of all, I want to thank everybody for joining, especially our panelists, Carrie, Daryl, Brianna. Thank you so much for sharing your insights. This is a much needed topic. We have a long way to go. Also, be on the lookout for upcoming training sessions. We have our next one on February 12th. There's a flyer circulated by email, and also please email me if you have any questions or interested in supporting. We are starting as a pilot program. We are going to collect data. Our hopeful goal is to merge this in the standardized patient program at the medical school level. So we do need your advocacy and support to make that happen. But the first step is to launch this and make sure we have a successful venture. I do have a couple minutes to say, past this, if there's any specific questions people may have. So thank you again for joining. We will stop the recording and have this available for anybody who cannot join. Okay.